Hello, everyone. My name is Miao. I'm an epidemiologist from Vaughan, Ontario, Canada. Vaughan is a birth registry in the province of Ontario. I'm going to present our research on the relationships between maternal neighborhood income, education, and the risk of congenital heart disease. Congenital heart disease, or CHD, is a group of structural heart defects developed during pregnancy and usually presents at birth or in early childhood. CHD is a leading cause of infant morbidity and mortality in Canada and worldwide. The prevalence rate has been estimated as 12.3 per 1,000 births in Canada. The etiology of CHD remains unclear. Previous studies have reported that certain risk factors may play important roles, including genetic factors, advanced maternal age, rubella virus infection, and exposure to environmental hazards during pregnancy, use of assisted reproductive technology or ART, certain medications, maternal social drug use, smoking, alcohol consumption during pregnancy, pre-existing maternal health conditions. Another potential risk factor is maternal socioeconomic status, or SES. A meta-analysis study reported that compared to reference groups, lower levels of maternal education, family income, and certain occupations increase the risk of CHD. The mechanism of this relationship remains unknown. A lower SES level may be a proxy of environmental and behavioral factors. In addition, mothers with a lower SES often experience poverty, which could lead to stress that may alter the immune system in pregnant women and thus possibly increase the risk of having an infant with CHD. However, there were inconsistent findings in the literature. Although Canada has a universal healthcare system, social equity has worsened in the past 2 decades. In addition, most studies were conducted outside of Canada. It's unclear that exists disparity of CHD by maternal SES. Therefore, we conducted a study to examine the relationships between maternal neighborhood SES factors and the risk of CHD. This was a population-based retrospective cohort study, including all singletons in later stage terminations, stillbirths, and live births between April 1st, 2012 and March 31st, 2018, Ontario, Canada. The study cohort was generated from several data sources. The baseline cohort was obtained from the Born Information System, or BIS. The other data sources were hospital inpatient records from CAHADAT, emergency room visits records from NACROS, the Canadian Census 2016, and postcode conversion 5+. This flowchart shows the data linkages from the study cohort. The cohort was first identified from the aggregate infant data in BIS. In this study, the exposures were maternal SES. We linked the Canadian Census 2016 and the PCCF+ data to obtain maternal SES factors at a dissemination area, or DA level, as maternal SES factors. The outcome CHD was captured from multiple data sources. We first linked the antenatal specialty and prenatal screening follow-up data sets to identify CHD during the prenatal stage and link the aggregate infant data set to identify CHD during birth or after birth in the bees. Additional CHD cases during birth or within the first year of infancy were captured from CAHA-DAD and CAHA-NECROS databases. Covariance for multiple regression analysis, including maternal age at birth, parity, ART pre-existing maternal health conditions, folic acid intake, substance use during pregnancy, were from bees aggregate pregnancy data. Infant sex was from bees aggregate infant data. In total, we recruited 804,292 singleton hospital births. We use unique health insurance number to link CAHA data and use the postcodes to link census data at the DA level. This table shows demographic characteristics and medical history by maternal median household income quintiles at a DA level. We can see here the mean of BMI decreased and maternal age at birth increased slightly from quintile 1 or Q1 to Q5. Maternal smoking, social drug, or alcohol use during pregnancy and mothers with mental health problems were more prevalent among neighborhoods with lower median household income. The patterns of demographic characteristics and medical history by education level were similar with that by the median household income. We found that the CHD prevalence was 1.21% in this birth cohort. These two graphs show CHD prevalence by maternal household income and education level, respectively. There were a downward trend in CHD prevalence from Q1 to Q5 on both variables. We further performed multiple logistic regression and found that compared to infants whose mothers lived in the highest household income neighborhoods, infants whose mothers lived in the lowest income neighborhoods increased the risk of CHD by 28%. Compared to infants whose mothers lived in the neighborhoods with the highest percentage of people with a university or higher degree, infants whose mothers lived in the neighborhoods with the lowest percentage of people with university or higher degree increased the risk of CHD by 34%. We also found infants whose mothers lived in the area with the highest percentage of all people with lower income or without high school diploma increased the risk of CHD by 13% and 19% respectively. In summary, we found a lower maternal neighborhood household income, poverty, and lower education level increased the risk of CHD. This study indicates a significant social inequity in Ontario, which suggests that health intervention and policy should target on lower SES families. There were a few limitations of this study which should be addressed in the future research. In this study, due to data limitations, we were not able to measure individual level SES and not able to take account of all potential covariants such as diet, exposure to environmental hazards, various infection, and genetic factors in the analysis. We would like to thank Born Ontario and CRHR for the support for this research. Thank you. Any questions?